Abstract about role of the endovascular intervention in the treatment of primary varicocele. My name is Dr. Muhammad Juma Barros, Vascular Surgery Department at Azhar University. At first, we speak about varicocele, which are dilated tortuous veins of the bambiniform plexus. These veins drains into the internal rheumatic vein, which is called the gonadal vein. Diagnosis of varicocele by history and physical examination, followed by imaging study, colored Doppler ultrasound. Indication for treatment of primary varicocele include infertility and pain. The aim of my work is to assessment result of endovascular intervention in the treatment of primary varicocele as regards its complication, its efficiency, its occurrence rate, to choose the best method for treatment of primary varicocele with least complication and higher successful rate. Methods for treatment of primary varicocele include laparoscopic, surgical, and endovascular. We speak about endovascular, which is limited to use of local anesthesia and cold sterilization. For vascular access, we do vascular access using 6 French vascular sheaths. For left side varicocele, the most common access is the right common femoral vein, and for right side varicocele, the most common access is the right internal jugular vein. This picture shows that the axis or cannulations of the left rheumatic vein from the right femoral axis, followed by insert of 0.035 inch hydrophilic wire, followed by 4 to 5 French diagnostic catheter, and the catheter tip is placed at the junction between the left rheumatic vein and the bambiniform plexus, guided by fluoroscope. How to choose my embolic agent? Choose embolic agent depending on the size of diameter of the gonadal vein. We can choose solid agent as coil in diameter high, and if low diameter we can choose liquid embolic agent only. In this picture we show that cannulations of the left rheumatic vein from the right femoral axis, and in picture B we show that phenography of left gonadal vein. In picture C we show that phenography of left gonadal vein with testis and collaterals between right and left gonadal. In picture E we show that coiling of in picture D we show that coiling of left rheumatic vein. In picture E we show that the coiling followed by embolization followed by coiling, which is called sandwich technique. In picture F, we show that complete obstruction of left gonadal vein after coiling. Post-intervention care, after removal of the catheter and sheet, compression of the intersite for about 2 to 3 minutes, followed by patient follow-up for about 2 to 3 hours after intervention before being discharged home. Our results show that about 20 percentage of the patients show post-intervention normal duplex, and about 86.7% of the patients show improvement of semen analysis. This present study confirms that the endovascular intervention in the treatment of primary varicocele is best method for treatment with low complication and higher successful rate, with avoiding use of general anesthesia and rapid recovery of the patient. In this picture, we show that the axis of left spermatic vein from the right femoral axis. In this picture, we show that axis of left gonadal vein and bambiniform plexus from the right femoral axis. In this picture, show axis from the right jugular axis, and this picture shows that axis from the right jugular. This picture show phenography of left spermatic vein. In this picture, show phenography of the testis and the bambiniform plexus, and this picture show insert of coil. This picture shows that after coiling and take phonography, after embolization and take phonography, we show complete obstruction of left spermatic vein. This picture we show that catheter tip is placed as the junction between the internal spermatic vein and the bambiniform plexus. In this picture, we show embolization during embolization of gonadal vein. In this picture, we show after embolization with complete obstruction of left spermatic vein. Thank you.
Wound care is not vascular, but at the same time, I can tell you wound care is really vascular, and every vascular surgeon has to have a good knowledge about wound care in general. But why we have a problem with wound care is what I'm going to talk about. First of all, I have no, good morning. Uh, sorry, sir. I have nothing to disclose related to this lecture. We all know what are wounds. I'm not going to define them, but generally, wounds and non-healing ulcers are very common. In the United States, we are talking about the 20 billion a year. Yes, with a V, not M. This is an old figure. We are talking about now 26, and in 5 years, close to 30 billion a year because of the aging population. The population here is aging, a lot of them in the nursing homes, and the care there is not the best when it comes to wound care. Chronic ulcer, as we define it, or it was defined for us, something that is not healing over a 6 weeks period the way it should heal. Doesn't have to close in 6 weeks, but it should follow a trajectory, that trajectory leading to healing. And in 6 weeks, for example, it should be like 40 to 50% at least healed. About 15% of the United States population will have at one stage, especially the older population, will have a diabetic ulcer or a chronic ulcer or any type of ulcer. And almost every year, about 2 to 3 million Americans will have an ulcer. I'm sorry, I'm talking about Americans because this is most of the information I got here. I tried to get something about the Middle East, but unfortunately, we don't have good data about the Middle East. We have some data, not good data. So how do we define wound, abnormal wound? It is either a wound that fails to heal or overheals. That is the simplicity of the definition. And a chronic wound is an acute wound with an impediment. And that impediment sometimes defined as the treating physician. So one of the impediment for healing are the treating physicians actually. And that's not what I said, that's what other people said. There are factors we know that interferes with wound healing. You know all this. But if you look at those factors, it's not only revascularization. It's a lot of factors interfering with wound healing. So it is multifactorial at least. You know very well, like I do, there are different type of ulcers. Not all ulcers are made the same. There are vascular, neuropathic, there are metabolic, hematological, traumatic, tumors, infections, fat necrosis, vasculitis, pyoderma, and much more, like sometimes hypertension, certain types of diabetes, not neuropathic. So a lot of causes for wound healing, for wound ulcers in general. So there are many types, different types. So that tells you one type of treatment is not going to cut it. It's actually multifactorial and different types. But there are guidelines. The guidelines for a good wound healing, good blood flow, no hypotension, smoking is a problem, sugar is a problem, temperature is a problem, oxygenation in general is a problem, debridement, devitalized tissues is very essential, and minimize the presence of hematomas, seromas if you do a surgical technique. So there are principles of management that you know very well, from treating infection down to improving the condition of the wound so that it can heal, and that includes bed preparation, topical application, callus removal. The European Wound Medical Association came with a statement in 2014 and reinforced in 2015 that managing wounds occurs only as a team. So this is the first principle. The first principle, wound management is not one specialty. It is management as a team. It should be patient focused. Referral mechanism is established for needed services, and it should be as early as possible in some cases, like infectious disease. Aggregation of assessment data to form a single plan for each type, and you need to follow that plan. That's what we call guidelines. and appropriate remuneration systems to help the treatment and the treating groups, and the healthcare system sensitive to team models. Disrupted teams will hurt only patients. This is the problem. If you look at the different types, that there are nursing dealing with it, surgeons dealing with it, physicians, podiatrists, etc., etc. Usually, when I get that patient, they send it to me either a wound specialist, then I look at the patient altogether, or sometimes it comes from a wound specialist to me as a vascular specialist. Then I look at the wound only, I look at the blood flow. And there is a difference between that. So if I look at the patient multi-specialist, which means I represent all the specialties in my wound center, then I look at everything. I start with the nursing. A part is the patient will serve in his home, in his nursing home. I look at actually his nutrition, etc., until I reach the blood flow, which is the last thing sometimes I look at. But if they send it to me to check his vascular blood flow, I just take general exam and then I focus on the blood flow. That's the difference between single specialty and multi-specialty. What about guidelines? Guidelines are made to guide rather than to strictly follow, but they are not made to be avoided. Usually, guidelines are made over a lot of literature review. For example, if the patient comes with an ulcer, you need to check the blood flow. You cannot ignore that if you are not a vascular surgeon saying, I'm not supposed to check the blood flow. The guidelines also says you have to debride the wound, remove the infection, get rid of the inflammation, you make sure the moisture is balanced, and make sure the epithelial edges are advanced. So this is what we call the time. There are so many acronyms. Follow any acronym you want, but at the end, they are all the same almost. This is what we call the time acronym. And there are different stages for the ambulatory care, from physical exam to surgical procedure, minor and larger procedure. And the last one is to make sure the patient is well served at home or in the nursing home or in the senior citizen home, wherever the patient is going. But whose job to make sure of that? If the patient is sent to me, do the vascular and tell him goodbye, the patient will come back. The ulcer is not going to heal. So the multi-specialty approach, which is the first principle we talked about, somebody has to champion that management. The champion can be a physician, can be an advanced nurse practitioner, or a physician assistant, can be a nurse. Somebody who will make sure every specialty took care of their job. This is principle number 2. You need to have a champion for wound management. The early treatment is essential, especially with infections. If you delay treatment with infection, revascularization, you increase the chance of amputation in those patients. The treatment should be patient-centered. This is principle or strategy number 3. The treatment should be patient-centered. What does that mean? Most of the time, the patient cannot walk. You are offloading them. The patient has difficult social support. Patient doesn't have money in many situations. This is where the patient-centered is, deal with all his care in a patient coordination. Referral is very important. Vascular, orthopedic, podiatrist, orthotist, and wherever it is needed, an early referral to ID. You need to make sure everything is done properly for that patient as a patient champion or as a physician champion or a nurse champion. From offloading, revascularization, compression, dressing, care coordination, infection control, this is not the job of each specialty. This is the job of the champion. The dressing, unfortunately, they are becoming very expensive. For example, there are 82 tissue therapy. They are ranging from $200 to $6,000, some of them. So you cannot go apply the $6,000 on an infected wound and you think this is going to work. You have to follow the guidelines, and when it is time to apply them to help the healing, you apply them. At the same time, the patient champion or the wound champion should make sure that this patient is not served by a high ticket. The lowest possible money to help healing should be applied to that patient. After each stage of management, principle number 3 is to evaluate the patient after each stage. For example, after diagnosis, you need to do what is the necessity decision and adds on reviews, goal achievement. So after each stage, you need to make sure you have served the patient in a way, don't cost him a lot of money, better healing, and less stress for them. Offloading, none of the physicians, other than those specialists in offloading, will know all those boots. I know some of them, the ones I use all the time. What I don't know, I get an orthotist to my clinic and I give him the patient, tell him, provide the best treatment for this patient, please, and let me know how much it will cost. If it is very expensive, the patient cannot afford it, then in that case, we'll go to the lower cost. Oxygenation. You need not to discard the effect of oxygenation on healing some wounds, like radiation wounds, osteomyelitis chronic, diabetic ulcers that are stages 3 and above. So you have to know when to use hyperbaric. And again, it can be multi-chamber, can be single chamber, and you have to make sure that the wound champion is organizing and reminding the physician, telling them, do you think this patient needs hyperbaric treatment? Again, it is multifactorial, as we said. There are myths that we all follow, and they are not true. First of all, wet to dry is a good treatment. Wet to dry is only there to serve the treating physician who doesn't know. Wet to dry has zero role almost nowadays in the treatment of those physicians, of those patients. The second myth, I can manage all ulcers. Nobody can manage all ulcers. You have to refer to a specialist at one stage. And no physician specialist in wound therapy can treat everything, even if they are certified wound. All care can be done in an outpatient setting. That is another myth. Sometimes you have to admit the patient and deal with the early stages or acute stages or difficult stages, then discharge them outpatient. Another myth, I don't have to get wound education or certification. It is like saying I want to be a vascular surgeon or a venous surgeon without getting certification or education in venous. The fact you are a surgeon or a physician doesn't mean you are a good surgeon, a good wound specialist. You need to get certified. Remember, the patients are older, multiple medical problems, non-ambulatory, need a caregiver, hospitalized and discharged. They need nursing homes, need home health, and lives alone in the United States. Many of them live alone, sometimes with a dog or cat, but they are not going to be served by them. So you need to look at all these as a wound champion. Again, wound care, multidisciplinary, multiple location. This is the fourth principle and strategy. You need to follow the patients in the different locations. And those locations is proven over and over by multiple publication that will help the healing. Can be home, nursing home, or a hospital. And we talked about already. The challenge is that it is so difficult to standardize the treatment because of different specialists, multidisciplinary, lack integration. No one specific wound care and vascular unit can help to treat those patients alone. You need to work with others. The principle of multi-specialty or disciplinary limb salvage is easy to understand, but you need different specialists to do that. Vascular surgeon is very important, plastic surgeon sometimes, podiatrist, orthopedic surgeon, and nursing care. Designated service champions are a must. You need to transcend being alone to being transdisciplinary. That's very important. Define your goals. This is the last strategy. Define the team, define the roles, decide who's the driver, and then this is how complex really is wound care. This is the way it is in our wound care. From the minute the patient enters the wound center or the hospital until they discharge. This is how many people are involved in it. Technology is there to help you, but it's very expensive. Limb salvage is very important, but it needs multiple systems and multiple teams. Patient-centered, it means don't send the patient to all specialists. Let the specialist go to the patient in one area that will help the healing, decrease the non-convenience. Protocol-driven, another strategy. So in conclusion, optimal wound care is a team process championed by a physician or physicians of any specialty, but executed through multiple disciplines, protocol-driven, patient-centered, coordinated at different stages. And thank you very much for the chance, and I wish you a very good conference.
Thank you very much, dear friend, Professor Dr. Muneir Nazal, for a great overview on the wound management.